We have a lot of major known experts in the field, many aspects of what has been presented. And I can see Dr. Macaroon there and Dr. Darling and so many others. So please, let's ask some real questions.
Well, thank you. I want to first thank Dr. VEITH and Dr. Shah and Asher for putting such a great session together. I was going to have a quick question and comment for Dr. Fujimura about the approach. Usually when you go posterior, did they always use saphenous vein for all of them? Because usually when we go posterior, we'll take the lesser or small saphenous if it's of good quality. And the other comment I would have is we try not to actually for small bypasses, meaning from the SFA to the proximal tibials. Usually we don't do. I wouldn't like not to do in situs to save as much vein as possible and either take the distal vein and reverse it or the proximal vein and go orthograde. Thank you. Great talks, everyone. I'm very proud to be here.
Thank you.
Thank you. No. So, any question for anyone? Or
For the popliteal entrapment, or
you want to take this?
Sorry?
For the popliteal entrapment.
Yeah, so...
Don't fight over it, folks.
So yes, I was surprised, how rare this disease was in Japan, because there were so many hospitals doing various surgery. The method is not, there's no consensus of how to do anything. So most patients that didn't have the experience just did the short bypass, as you said, from the medial approach using the great saphenous vein. But as you said, I think posterior approach is much better because you can expose the muscle, and also maybe you can just do myectomy and finish. But also one thing I noticed in my research was that the occlusion was very frequent. So I think that's delayed the diagnosis in Japan, and that's a big problem, I think. Thank you.
Dr. Sidawi, Vice President of every society that existed. Please.
Thank you, Dr. Asher. You're always ahead of me, though, in every society that existed. Very good. Excellent, really. All the presentation was superb. Excellent session. Thank you very much for putting it together. I can ask a question for every presenter, but obviously I can't do that. I'm going to ask Dr. Cole and the definition of CLTI and the global guidelines. You stated there a ulcer and also diabetic ulcer. Are these standalone definition, or they have to have ischemia with them? Because as we know, diabetic ulcer can happen because of neuropathy while the patient's got papillary pulses.
We need to have ischemia. We need to have hemodynamic signs of ischemia, plus any of the following that were listed in the slides.
So ischemia plus all these. Okay, thank you very much.
Hemodynamic sign.
Philippe, I just want to follow up on this issue. I mean, so many people put so much work in these global guidelines and the Wi-Fi and the glass. Everything has been validated. But how often are people actually using them? I understand the value, but in practicality, how often? It's like the CAP classification. Everybody just use the class. They don't use anything else when they report. What do you think about that?
Well, I think that we need to hammer on the nail a lot. I think that's if you compare to where we were probably in 2019 when it went out, and in 2022, I think there are more and more reports in which the class is begging or has been validated. More and more talks about that. We have an app also that has been developed. But I agree with you, Enrico, that we need to keep working on that. I think if I may compare in cardiac surgery, that's the syntax score, which was introduced, in 2005, actually, something like that, when they started the syntax trial comparing PCI with CABG. And I think you still have cardiologists and cardiac surgeons that don't use the syntax score, but now it's really into practice, and you would not accept a report on a major trial or even a publication without having the syntax score of the patient. So I hope, and we hope with Joe, Mike, and so forth, that we will be there at some point in the next 5 years, maybe.
Great, thank you. Dr. Grovitsky, please.
Enjoyed very much the meeting. I remember it was exactly 15 years ago that we established this federation in Madrid on September 21st. And we still have, I just looked up the founding document. It's really good to see that this federation persists, and congratulations for all the presentations. My comment is again to President Kohl, who said that we need to upgrade the guidelines. And we just heard this afternoon the best CLI trial, and I'm just asking him, what specifically, which recommendation will be changed in the global guideline? What do you think, Philip,
Peter,
based on the CLI?
Well, I don't know,
Trial.
Peter. We haven't started the discussion, so it's a process. I think the way I would suggest is that we, or the people that are going to be involved, we look at all the recommendation and see whether this recommendation needs to be changed, upgraded or downgraded, whether the level of evidence is the same, because it can be also important to have the same recommendation but with a higher level of support using. So of course, I guess that the best CLI trial will have an impact, such as also the Voyager trial that I mentioned for antithrombotic therapy. I like the conclusion about the fact that saphenous vein is great again.
All right. Dr. Wei Zhu,
So
please.
this question is for Dr. Suresh Ru. So Ehlers-Danlos is, we know, is really difficult pathology. Tissues seem to be more friable than Marfan syndrome. Now, our own experience and some of the data show that endovascular repair for Ehlers-Danlos seems better than open repair versus compared to the Marfan syndrome. I wonder if your experience show the same.
Right, so what we've learned is two things. One is that for medium-sized arteries, endovascular repair is definitely superior to open repair. So medium-sized arteries, Viabon stents or VBXs potentially. Mostly I prefer Viabon stents, so that's medium. For the abdominal aorta, the question is, what is the mutation? And what I'm noticing is that if you have a null variant, this is why it's important to know what the mutation is. People with null variants have normal collagen, but they make 50% of the collagen as the average person. That is very different than the people who have the other kinds of variants. For example, large amino acid substitutions, their tissue is incredibly weak. So in those circumstances, EVAR is probably not a good option, but I think in null that we can get away with EVAR. I only have 2 cases that showed the excellent remodeling, so we're going to publish those. But those are different than the other people. And we're going to know more. This is the whole point of having this study, to understand this genotype-phenotype. But every time somebody calls me, the first question I ask is, what's the mutation? So I want you to get comfortable with the idea of asking for the mutations. If you're publishing any case reports, please put the mutation in the case reports, and that's how we're going to learn.
Shireen, just to follow up on this question too. I know very little about this subject. I had maybe a couple of patients in my life that I took care of. But there are several types, as you mentioned. But which type is the one that absolutely, the intervention will end up in a disaster versus the other ones?
Right. So Ehlers-Danlos syndrome is very, very broad, and there's 13 subtypes.
Right.
Only 5% is the vascular subtype. And the one I talked about today is vascular. And within vascular, there's the null variants, which are 5% of that. And then the rest are the other kinds.
Okay.
And so there are no guarantees that any of them will end with disaster. I've operated now on people with horrific tissues, and we're able to get them through just fine. So I think when you know the diagnosis and you're prepared for them, you can get them through surgery. The catastrophes happen in the setting where somebody goes in, not knowing what they're dealing with, and then surprise, everything is falling apart. And by then, you're really behind the 8 ball at that point, because nothing is prepared, nothing is ready. So that's why a lot of my teaching over the last 5 years has been to how to recognize the disease, so you know what you're dealing with a priority, instead of you being surprised in the operating room.
Excellent point. Thank you very much. Dr. Macaroon,
Well,
please.
thank you, Palma, for putting this thing together. It's really outstanding, and all the presentations were amazing. I just had a question for some more regarding the companionship program. which probably goes to the core of what the World Federation could be doing for the rest of the world. I'm sure the needs of those mentees are quite different. Can you please elaborate a little bit about what most mentees that you're aware of are interested in? Are they interested just for remote help, or actually hands-on experiences, or long-term relationships? Maybe that can help in providing you even with more mentors.
Thank you very much. That's an excellent question. That's one of the areas that we're actually asking in the expression of interest form. We'd like to actually inquire from them what are the areas of deficiency in their current practice. And I like to use that word contemporary vascular surgeon a lot, because one of the reasons why I think vascular surgery is behind the other specialties in these countries is that you have that traditional general surgeon that occasionally does an embolectomy and they say, well, I also do vascular. And I think vascular surgery obviously has moved a long way from that, and that's why the need is perhaps not seen in those countries. So in many of these places, we actually have to, there's some information that needs to be provided to these people of what vascular surgery can do in terms of limb salvage, etc. But to answer your question, I think once the companionship has been established, generally speaking, a mission to that country, a 2-week visit, is important by the mentor who goes there to sort of assess and see what the needs of those areas are. Generally speaking, AV fistulas are a major need in many of these centers. Distal bypasses are very important. And also, I think peripheral endovascular procedures are important as well. You know, we think about these procedures as being very expensive, but if you think about it, many of these countries, they can still afford $300 for a sheath of wire and a couple of balloons to balloon angioplasty a vessel. And they have the infrastructure to do that in many of those centers. So I'd say those would be the primary things to focus on in that companionship. But would love to chat more about it afterwards. Thank you.
Good point.
I have a question for Dr. Venermo regarding her carotid study. It looked as if you determined that people are really not following the guidelines. There's still this wide variation. Do you have any thoughts as to how you can have people accept the guidelines and follow them more closely? Is there a way to eliminate this variability?
Can you repeat? I didn't hear the first part.
Well, I believe she pointed out that there was, after that study was published with guidelines for carotid management, it turns out that people are still not following the guidelines and there's still wide variation in practice. So my question was, how can we address this, or how can we increase the applicability of the guidelines in practice for this disease?
I think we need to be very proactive towards the countries that needs more the most the application and the use of the guidelines. And I think this is really, and you and I agree on that a lot, Palma. It's what the World Federation is about. It's about promoting education through countries that need it the most, and I think this initiative of the guidelines and also the global companionship or the distal bypass Olympics all goes into the same direction of education. And I think down the road, the guidelines give a roadmap how to treat these patients the most appropriately. I don't know if I answer your question, but
yes, and I think that's applicable for any guideline.
Yes.
Maybe Dr. Venermo can comment based on just carotid specifically.
Yes.
Yeah, that's a good question. I read a VEITH study where they had asked individual surgeons what is their attitude towards asymptomatic stenosis, and it was very interesting because it varied from, they asked, do you perform surgery? From 0 to 100%. So individual surgeons and centers have very different attitude for this. I would like to interview surgeons and try to find the reasons. Of course, one reason is reimbursement system. It's very I mean, I can understand it very well. In Finland, we follow guidelines very strictly, and we have always, when a new guideline is published, we have a meeting where we sort of discuss whether the guideline have an impact for our practice. But I think that this needs more investigation.
Yes, sir.
Hi. I first wanted to say to all of you that I was very impressed by the quality and the extreme difficulty of the cases that you presented. Just to answer your question, maybe the answer would be malpractice. In other words, if you have a case that doesn't go well after carotid or after anything, and then you ask an expert witness or the judge, and that it turns out that the guidelines haven't been followed, then you have a punishment. And then we go back to the ethical aspect of our profession.
I fully agree with you. I fully agree with you.
Merci beaucoup, monsieur.
Je vous en prie.
Okay, I want to ask Dr. Noronen about the when to do the debridement of the infected foot and when to do the bypass. What's your approach, basically? You do first the bypass no matter what, or you go ahead and you debride the foot that looks infected? Because some of the feet you showed, maybe there's a lot of underlying infection and pus, and that becomes an issue. To what to do first?
Well, if there's acute infection, it's debridement straight away, even in the middle of the night. That's the first thing. And then, depending on the status of the ischemia, usually we get vascular imaging on call as well. So we basically know that what's the revascularization needed. If it's something that we think we can treat endovascularly, then it's the next or in the following days.
Yeah.
But of course, if it requires like a long bypass, then we usually do it the same straight away as well.
Mm-hmm. And if you have an infected foot, like the ones you showed are pretty impressive, and you have a calcaneus wound, and you need to do a plantar bypass, would you do that in close proximity to an infection, or what? Because there's another issue that always comes up: is how close to an infected site can we actually do the anastomosis?
Yeah, that is true. Then, of course, you have to start the surgery with the debridement so you can see where is the good tissue, where the line is, and whether there is. Because we use a lot of negative pressure wound therapy, so if it's not needed right away, so to grow, and then we also collaborate with our plastic surgeons. Because then we usually have, if it's like a heel, we have to consider some form of flap surgery as well.
Thank you. 6:30. Yeah, well, it's 6:30. That was a great session. Hopefully we'll have it every year. And I'm just sorry for all these people that missed this great session. Maybe we should do it a little bit earlier. Thank you very much. It was a great panel.
I just want to say... I just want to say thank you, and Dr. Bayat would like to invite everyone down for a celebratory beverage, and he'd love to answer more questions about the Global Companionship Program down at the bar at the Bridges, right after this if you want.